Hello everyone, my name is Nguyen and I'm a research data analyst at Boston Medical Center. Today I am honored to present the work of the Optimum study in increasing access to mindfulness for persons with chronic low back pain in a telehealth-delivered pragmatic trial. Mindfulness is recommended as a first-line non-pharmacologic treatment for chronic low back pain patients. Traditionally, group mindfulness interventions have been delivered in persons, but access to this treatment has been limited. The virtual platform may improve efficiency and create access for more individuals, such as people with lack of transportations or limited mobility. Therefore, the Optimum study aims to integrate a telehealth group-based mindfulness stress reductions program, also known as the MBSR program, into primary care settings for patients with chronic low back pain. In these presentations, I will outline barriers to a virtual group mindfulness interventions and how we apply innovative and inclusive strategy to ensure equitable access. And as of September of this year, we successfully recruited 451 participants from three different healthcare sites in Boston, Pittsburgh, and North Carolina. The participants were randomized into two groups. The first group is the usual care group, where participants receive care from their primary care provider. The other group is the 8-week mindfulness pain management program delivered through a telehealth platform. This slide, you can see that we have successfully recruited 228 participants for the control group, also known as the usual care group, and 223 participants for the interventions group, also known as the 8-week virtual MBSR program group. And to give you more information about the MBSR program that we implemented in this study, in each sessions, an experienced MBSR instructor lead the intervention for 2 hours with the co-leadership of a study clinicians and support from research staff or technical assistant. After randomizations, the study follow-ups with the participants for years, and data is collected through the RedCap system. To ensure smooth delivery of the virtual group mindfulness intervention, the study collected qualitative interviews with study participants and feedback not only from the research staff but also from the community advisory board, which is composed of stakeholders from various backgrounds like healthcare professional, patients with chronic low back pain, and mindfulness experts. In the next slide, I'm going to discuss further major challenges that we identify and strategy to overcome these challenges. Technical and interpersonal challenges were identified as two major barriers to care that study participants experienced in this trial. We recognize that some participants did not have access to smart device and some were unfamiliar with video conferencing software. To tackle these issues, we proactively offer additional resources such as phones, tablets, and headphones to ensure that they could fully participate in this research. Before randomizations, we organize one-on-one and group technical orientation to familiarize participants with the video conferencing platform and ensure they were comfortable and confident during the study. Our study staff was also available during the intervention sessions to provide technical support. Considering interpersonal obstacles, we anticipate that participants may feel less connected and more prone to distractions compared to traditional in-person settings. To mitigate these challenges, we use creative materials like newsletter and animation video about the study, as well as clear communications about the mindfulness concept during the study enrollments and throughout the study. This approach ensured that participants were introduced to the study in an engaging and informative manner, setting the stage for an inclusive experience. Additionally, building trust and rapport remain a cornerstone of our strategy. We utilize empathetic language throughout our interactions, expressing understanding and support to create a strong sense of connections with participants. For instance, the study clinician used the Zoom breakout to facilitate the check-ins and give participants the space to share about their week during intervention sessions. Mindfulness instructor utilize the Zoom whiteboard feature to create interactive activities and encourage participations, while study staff send like weekly reminder and session note to keep participants informed. Finally, we acknowledge that privacy concern could be a notable issue for some participants when meeting virtually. Therefore, we emphasize the importance of participant privacy by advising them to choose a quiet space to attend the sessions and turn off audio and camera feature when needed. This gave participants the flexibility in choosing the engagement level as well as respecting other participants during meditation time. These strategies collectively contribute to replicating the rich and interpersonal dynamics often present in person mindfulness interventions, ultimately enhancing the overall quality of the virtual experience. As a result, the study successfully recruited a diverse group of participants, 451 participants with a mean age of 52 and standard deviations of 14.6. The majority were female. 41.5% were non-Hispanic Black and 45.2% were non-Hispanic White. Furthermore, 33.8% held a high school degree. A significant 70.5% of the study population has endured chronic low back pain for more than 5 years, and 31% reported an income of less than $25,000 annually. In this slide, I wanted to highlight the critical need to address barriers that hinder access to virtual mindfulness programs. Our research data indicate that only 21% of our study participants reported being not at all, a little bit, or somewhat comfortable when using video conferencing program. And so when we delve into comfort level and categorize them based on income level and education level, a pronoun disparity emerge. Amongst the 6% of participants who expressed not at all comfort with the video conferencing platform, a substantial 58% had an income below $25,000 annually. If you're looking at the chart, the second chart in the bottom left, and also 43% have a high school degree. That will be indicating in the third graph on your right. These findings emphasize the impact of social economic status on participants' comfort with technology, as well as patient use of telehealth services overall. So, by implementing those comprehensive strategies that were described before, we were able to create an accessible and welcoming virtual platform for our study participants. In this slide, I wanted to share participant quote from the post-intervention interviews. One participant shared, I picked it was with a class. It would be the same way as it was online. I didn't feel no difference. Just because we weren't face to face because of COVID, even if COVID wasn't there, I can visualize us in a classroom. Another participant shared, I'm glad that I learned meditations with you guys and I am happy I'm trying to do it every day if I can. In conclusion, virtual mindfulness-based group visit hold promises in expanding access to care for underserved populations with chronic low back pain, and barrier to virtual care delivery can be overcome with thoughtful planning. To enhance virtual MBSR program, we suggest providing guidance on telehealth platform navigations for participants, incorporating interactive elements into the curricula, and creating a supportive learning environment. These improvements will make virtual MBSR program more accessible and effective for underserved individuals with chronic low back pain. I hope that I was able to share some helpful tips from our experience for current and future clinical trial to learn and apply for. Lastly, I would like to thank the help and support of my principal investigator, Dr. Natalia Morone, and my Optimum Research team. I want to acknowledge the NIH NCCIH, the HEAL Initiative, and the NIH Pragmatic Trial Collaboratory, and thank you for listening to my presentation today.